There is only one species of animal on planet Earth or on any planet that I know of that is confused about what foods they should eat and what foods they should avoid. It seems that every other creature on planet Earth knows exactly what they should eat. They know how much they should eat. They know when they should eat, and they know when they should stop eating. Only human beings seem to have a problem understanding what a proper human diet is. I've got a great guest with me today, and we're going to be talking about a proper human diet, and no telling where this conversation is going to go. My guest is a bit of a rebel like me, so there's no telling what we'll wind up talking about before this interview's over. Welcome, Dr. Paul Mason from the other side of the earth.
G'day, Ken. It's absolutely wonderful to be here. We've had a couple of false starts here getting this done, and I'm really grateful to be on your program.
Absolutely. Now, it's actually tomorrow morning where Dr. Mason is compared to where I am. I'm about to wind my day down, and he's just getting his day started. So, Dr. Mason, welcome. Before we get started, give us just a brief 30, 60-second bio about you and why did you become interested in a proper human diet?
Well, basically, for my own health. So I used to have metabolic syndrome in my 20s and 30s. I'm now in my 40s, and I no longer have metabolic syndrome. So that's a bit of a win. I'm a sports medicine physician. So we've got a natural interest in human performance. So we deal with elite athletes, Olympians, and the like. So it's kind of useful if we can put them in their body and running the way it's meant to run. And there's also a rich heritage of proper human nutrition in sports medicine. We've got Dr. Timothy Noakes, Professor Timothy Noakes, and Professor Peter Bruckner, who are both leaders in the field as well.
Absolutely. And now this is being recorded live in our private community. And so one of the benefits of being in our tribe is that you get to ask questions of some of the world's leading thinkers on health, medicine, nutrition, sports medicine. And so we might entertain some questions as I see them go by in the comments. Doc, first of all, I've seen you talk recently. I was doing my research about you to make sure you're legit. You were talking about hemoglobin A1C measurements and plant sterols and the effect that eating some plants, at least some of the time, can have on the health and viability of erythrocytes, red blood cells, and how that can affect hemoglobin A1C measurements. And I've actually about 5% of the carnivores in our community, we see that they get this falsely elevated A1C, and so I'll be using different numbers than you. In the United States, a 5.6 or lower is considered completely normal, but we'll see carnivores get a 5.7, 5.8, and they've been strict carnivore for 6 months or 12 months, and so we know that that's not coming from glycation events coming from their diet. There must be some other cause. Tell me what you've learned about A1C, plant sterols, and how they can affect reticulocytes and erythrocytes.
Well, first of all, let's have a think about what HbA1c is.
Yes.
So you've got a red blood cell and it's swimming along in a soup. And when we talk about blood glucose, when you do the finger prick and you say, oh, there's glucose in my blood, you're physically talking about glucose molecules that are swimming along in this soup. So these red blood cells also in your blood, they're in contact with the glucose. Now, these glucose molecules can actually non-enzymatically, which means it's just a passive process, can attach together. And when the glucose attaches to the red blood cell, we call that glycated. We call that HbA1c, glycated hemoglobin. Now, the more sugar that attaches, the bigger the number. So there's two factors that can actually increase the HbA1c. So factor number one is how much sugar is there. So that's why people with diabetes have greater HbA1cs, because this soup, it's a thick, viscous soup of sugar. It might as well be honey for blood. But number two, the duration of exposure. So if those red blood cells are in that soup for longer, then there's going to be naturally more time for things to attach. And that's what happens in carnivores. You see, we talk about red blood cells like they've got a life of 120 days, but not in everybody. Some people's red blood cells just aren't that healthy. They don't live as long. They suffer more oxidation stress. They're not as resilient. They're not as deformable. There are myriad of reasons why. But if their red blood cells are not lasting for very long, then what will actually happen is you'll get an artificially low HbA1c reading. So people who are sick, I'll often see people with an HbA1c of 4.5 or something like that, and I'm just saying, that's not real. We've got to look at a reason why are your red blood cells turning over excessively. But on carnivores, they put their body into a physiological state where the red blood cells can actually live for longer. Their survivability is improved. And in that situation, what actually happens is that because they're in contact with the sugar for longer, they're able to actually have an elevated HbA1c. Unfortunately, there is a way we can actually assess for this in the blood. So when we do a full blood count, we get hemoglobin, red cell counts, so on and so forth. And we can also get, although we don't always ask for it, something called reticulocytes. Now, a reticulocyte is a new red blood cell. Now, I'd call it a baby red blood cell, but they're actually bigger.
Yep.
So we'll go with a new red blood cell. And the idea is that if you're in a steady state, if your red cell count is stable between two blood tests, then the rate of red blood cell production should be a pretty good surrogate marker, a proxy marker for the rate of red blood cell destruction or turnover. So what we can actually see is that in carnivores, their blood cell amount is staying stable, their reticulocyte, their new red blood cells are going down, and at the same time, their HbA1c is going up. So that gives us an insight that the increased HbA1c is actually a consequence of improved red blood cell survivability. So how on God's green earth does this come about? So we've heard of cholesterol, this molecule which is absolutely essential for life. But have you heard of fake plant, fraudulent cholesterol, imposter cholesterol, phytosterol? So this is what's in seed oils and plant foods. And this is molecularly very, very similar to actual real cholesterol. It's just got a bit of a tweaking on molecular side chains, and it can actually be absorbed in small quantities by the body, but because it is different, it doesn't have the same biological function, and it gets incorporated into red blood cells, which, by the way, the highest concentration of cholesterol in any cell membrane in the body is in red blood cells. So red blood cells take it up. And if red blood cells take up this fake plant cholesterol because you're consuming too many plant, seed oils, so on and so forth, it actually damages them. There's clear evidence, and this has been studied, that when you increase the phytosterol content of red blood cells, they become fragile, less deformable, they turn over quicker. So that's why if you had a diet high in seed oils, you could actually see a paradoxical lowering of your HbA1c. Now, I know not part of your question here, but just while we're talking about, so if you have a HbA1c, what do we do? Well, I would recommend cross-referencing it with what I consider to be the gold standard for glucose measurement, glycemic assessment, which is a 24-hour or a continuous glucose monitor. And they are absolutely beautiful. So that's real-time measurement, wirelessly going straight to your phone. You'll see in real time, it's like what we call the election night worm, which political party is winning in that seat. You actually see your sugar trace in response to whatever foods you're eating. And if you've got great glycemic control, you will see this. Just a couple of points, though, that is often overlooked on continuous glucose monitors. They do not measure the concentration of glucose in the blood. So, and this is often, people will say, my sugar goes high, I have a shower, when I exercise, my sugar's going way up. And it's like, your sugar's not going way up. Let me explain what's going on. So you've got the little probe from the 24-hour monitor, and that sits in what we call interstitial fluid, not exactly in the blood. So what happens is the blood is flowing around, it's delivering glucose molecules, and some of those glucose molecules are escaping and going into the interstitial fluid. So the interstitial fluid reading of glucose is dependent also on two factors. One of them is the concentration of glucose. The other one is the speed of blood flow. The greater the blood flow, the greater the delivery of glucose to that sensor, which is why if you have a hot shower, you vasodilate, you open up your blood vessels, you increase the blood flow, it looks like you're getting a spike in sugar. You're getting a spike in blood flow. Same when you exercise. You're increasing your circulation, you're increasing the delivery of glucose to the sensor. And that's why there's not always a direct one-to-one relationship between the finger prick blood glucose, which is more accurate, and the continuous glucose monitor. But the continuous glucose monitor will tell you if you've got stable sugars. And if you've got stable sugars, you're sitting fairly pretty.
Yeah, I totally agree. And there's a long list of things that can falsely lead to an elevated A1C. There's a long list of things that can lead to a falsely depressed or lowered A1C. Chronic alcohol intake can actually give you a falsely low A1C. There's a long list that anybody can look up. And so when I see a carnivore, and I don't see this in people eating a ketogenic diet. It's really only in carnivores or ketovores who are just almost carnivore, 95%. But I'll check either a fructosamine or a glycated albumin. And invariably, even though the A1C is a little bit elevated in these carnivores, the fructosamine or the glycated albumin is stone cold normal, which I think is another good way. And I love your reticulocytes. That's an excellent way of looking at this to see how many new young blood cells are out there in the circulation. Why are you having to create so many of those? Well, it's because the degraded red blood cells that have the plant sterols, they're being preferentially broken down and destroyed by the spleen and other parts of the body because they're improperly made. I think that's an excellent insight.
Well, just one thing there, Ken, though, just on fructosamine. So fructosamine is analogous to HbA1c in that there's a protein called albumin, or right. Albumin, as we might say down under, right. From the antipodes.
Yes, albumin.
Now albumin is what we call a negative acute phase reactant. Yes. So now what does that even mean? So basically, in a normal existence, healthy existence, our liver produces lots of proteins, which is good because we need proteins to live. But when we're sick, we have other proteins that the liver produces, like C-reactive protein. That's an inflammatory protein. But there's a finite synthetic capacity in the liver. It can't just say, oh, I'm going to produce more CRP now and not subtract away from something else. So your albumin production will actually reduce when you're actually inflamed and chronically inflamed. And the change in albumin synthesis rate can actually impact on your fructosamine as well. So fructosamine is not removed from having extraneous factors that can impact it in the same way that HbA1c can. So, so absolutely, I do use fructosamine from time to time, but I still always come back to the continuous glucose monitor.
I love that. Yeah, 24-hour continuous glucose monitor. It's hard to beat. Now, I always love to point this out because there's a few people in the carnivore community now calling it animal-based diet who eat hundreds of grams of carbohydrates a day in the form of fruit and honey. And I actually had a discussion with one of these folks. We won't name any names, but he and I are good friends. But he said that the hemoglobin A1C and fructosamine tests, they absolutely test for fructose glycation as well as glucose glycation. And I was like, I don't think so, my friend. You maybe need to look into that. And so let's be very clear. Even though fruct is in the name, it only checks for glucose glycation. It does not monitor.
And here's the other problem with fructose is that the glycation potential of fructose is 7 to 10 times greater than that of glucose.
Exactly right. And so these people who are eating lots of fruit and honey are getting a gigantic amount of fructation or fructose glycation that no test at the doctor's office can detect. And so I always like to make that point because it's confusing for the layman. Say, well, it says fructosamine. It's got to measure fructose. No, it doesn't. And don't feel bad if you're a layman and you thought that, because some doctors don't know that it only checks for glucose glycation, as does the glycated albumin. They do not check for fructose glycation. And so that's very important for people to understand. Now, are you a big fruit and honey eater as well, or do you believe that's probably not the best choice?
Look, for me, I don't think it's the best choice, but I don't want to be dogmatic about this. So this whole thing about carnivore, it's turned into a bit of a dogma, an ideology, if you will.
Yes.
And my personal belief is that people who are metabolically healthy probably can tolerate certain amounts of sugar. And I have a sneaking suspicion, which I think will be borne out in future, that a lot of these plant food intolerances that we're actually seeing, that we didn't see in generations gone by, is actually a direct consequence of alterations to the way food is produced. Namely, they're to a lesser extent nutrient deficient, and more significantly, pesticide adulteration. So in Australia, so here's a pop quiz here for you. So I'm a farmer. I'm growing wheat in Australia. I want to turn it into bread in the future. How many days before I harvest that wheat am I allowed to spray it with Roundup? 0.
I don't know what the regulation is in Australia.
6 days. And okay, so and if I spray a crop with Roundup, we often do it while it's growing. So the whole thing about GMO modified organisms is not worried about the genetics of it. It's designed to make it resistant to weed killers, so we can spray the crap out of them with weed killers so that only one thing grows. That's the whole point of a monocrop.
And
now,
the reason that they would spray it 6 days before harvest, a lot of people don't know this, Dr. Mason, is that desiccates, that dries the crop out so that it's easier to harvest.
Exactly. It allows for a much more rapid harvest. But often they're not just spraying it on at the end, they're also spraying on it when it's rapidly growing. Now, what do grains do when they're rapidly growing? They take everything up from their environment. So when you've got a crop that's been sprayed by pesticide, it is actually internalized. You cannot break it down by cooking. You cannot wash it off. The rate of pesticide exposure is increasing exponentially. So a World Health Organization report calculating the worldwide per capita for every single person in the world use of pesticides has estimated that in the last 30 years, there's been 11 kilograms of Roundup applied to our food for every person on Earth. And 70% of that has been applied in the last 10 years. I mean, and that's just one single pesticide. You know, there's numerous version. So this whole thing about, and the pesticides has incredibly wide ranging. I know we probably didn't want to get too much into the weeds on this kind of topic today, but I mean, we have to understand that what this does is it destroys the soil. So all the fungal elements and all these protist elements, the things that are necessary for soil structure are destroyed. Now, sure, that doesn't sound like a big deal, but where does the nutrition, how do we release the nutrients from the sand and the stone and the clay from the soil? It's with these complex ecological, biological forms. And the pesticides just demolish that, which is why when we perform nutrient analysis on fruits and vegetables today, compared to earlier, many nutrients are down by at least half, often up to 3/4. And a lot of the data that I've been able to get is still 20, 30 years old, which doesn't incorporate the recent massive increases in fertilizer use. So when I come back and say, look, this is not an ideology about carnivore plant foods versus, so on and so forth, we have to understand that our very food systems are not the same. So sure, if you want to eat plant foods, and they agree with you, and you're not celiac and you're not reacting to gluten, so on and so forth, then there's no ideological reason why you ought not do that. But I would strongly encourage you to make sure that it is organic. And even if you're eating organic foods, that doesn't completely eliminate your exposure to pesticides, but it has been proven by research to reduce it significantly.
Yep, I totally agree. And in many cases, I've read all the studies you've read about the decrease in the nutrition in plants, in grains, and in actual vegetables as well. And in many cases, when the researchers look at the soil itself and do chemical analysis, the vitamins and minerals are in the soil,
yes,
but it's
just not released.
All the bacteria and all the fungus. That's that beautiful, currently indescribable, ununderstandable food, that soil web of life. That's how the minerals get into the vegetables or the wheat. And when you destroy that with fungicide, pesticide, herbicide, it might be in the dirt, but it's not going to get into the plants. And that's a huge problem. That's a huge deal. And I love it that you know that about raising crops. That's good information. Most people not aware of that. You talk a lot about statins. I talk a lot about statins. We talk about cholesterol. I understand that you've got some newish information on statins, because one of the main problems I have with statins is that the drug companies will not release the raw data from their studies. We just have to blindly trust them that the study was properly designed, that it was properly conducted, and that they got the numbers they actually said they got. And I understand that you've got a little bit of insight on that situation.
I mean, this is a complete debacle. I mean, the fact is that you and I, as independent doctors, independent researchers, do not have access to the raw participant level data on statins is just astonishing, that we have to accept at face value what these pharmaceutical companies, who have this obviously desire to increase their profits. So if we go back to, we all know about the Oxford University and Sir Rory Collins and, you know, all of that. But in 2013, there was the Cochrane collaboration did what's called a systematic review on statins. And they said, we found in some benefit, but they acknowledged the possibility that perhaps if they had access to the full data, that are unpublished data, that perhaps their results might change. So in 2012, there was an agreement with drug companies around the world for them to provide access to unpublished data. So two authors from the Cochrane collaboration, they actually approached drug companies and they made 10 submissions using these convoluted approaches to drug companies to say, look, can you please give us your unpublished data? So obviously, you know, statins are a wonderful drug. You know that, we know that. If you give us the unpublished data, we'll be able to tell the world the convincing truth. So of these 10 submissions, 2 companies didn't respond, flat out didn't respond, so much for an agreement. Then we had AstraZeneca. They declined on the basis of their internal company policies, which makes me wonder how the company was able to make this agreement. Pfizer, you know, we may have heard of Pfizer too, they said, I would love to, but we actually didn't collect any data on the side effects of our drugs, of the statin. Sorry, I'm not talking across their whole product range. That would be speaking out of turn. Other companies, they said that the statin data was collected before they formed the agreement. Therefore, it doesn't form part of the agreement. In another situation, the company said, the period where we're required to retain the data for the statins has lapsed. So presumably they just burnt the data rather than having it be released transparently. A Japanese company, now this is very interesting, the one that was researching the very first statin, Sankyo, they actually specifically excluded statin data from the drug sharing agreement, almost like they had something to hide. Now, the really interesting thing is that this company was actually in a race with Merck to develop the first statin back in the 1970s. And it's on record, there is some documentary evidence that they stopped researching the first statin because it was causing too many cases of cancer in their test animals. And gee, it would be wonderful if they hadn't excluded that data from this data sharing agreement, wouldn't it?
Yes, that would be very nice.
I mean, wouldn't you love to have your hands on this data? But the simple fact is, you know, we say we've got all of this data, and this information was something that unfortunately I didn't have room for in my lecture, but I probably should talk about it. I'm glad that you've given me the opportunity to talk about it publicly today. But the fact is that the drug companies do not give us access to all the data on side effects. And even when they do give us data, the data that they curate, that they want us to see, the benefits on statins are marginal at best. Now, technically they are there in the matter of, you know, it might increase your life expectancy by 3 or 4 days. But, you know, would those benefits vanish if we had access to the full data? And that's a question we don't have the answer to. But in my head, I think I know what the outcome would be.
Yeah, me as well. And so the 10 companies that were responsible for the majority of statins on the market either just didn't reply at all or said, no, you can't have that, or we've destroyed that data. Even though much of this data, many of these studies were actually paid for with government dollars, aka
on the public dime. Yes,
right?
Exactly right.
But yet somehow they own the data, even though it was paid for by the people.
And not only that, understand that we're wanting data on personal individual side effects. We want to know what happened to Mr. Joe and Mary when they took the statin. Did they get muscle aches? Did they start weeing blood? Did their liver start cooking itself? So this is individual data.
Yeah, it's crazy. And speaking of drugs, statins are very often part of a pharmaceutical soup that patients, especially over the age of 50, they're going to be on a statin, 2 blood pressure medications, 2 diabetic medications, medication for restless leg, a medication to help them get to sleep, a medication to help them stay awake. Polypharmacy. Now, I know you have some rather strong opinions about this, and most of them align very closely with my beliefs. Listen, I used to be guilty of this, Dr. Mason. Let me be the first to fess up. Early in my career, when somebody would come to me on 5, 10, 15, 20 different prescriptions, and they'd be like, yeah, I'm just here to get labs and get my refills, I would refill every single medication. I never went down line by line. Do you still need this? Do you still need this? I never did that. It never occurred to me to do that. I thought my job was just to refill everything. I'm not joking. I'm serious. Yeah. And now I would never in a million years do that. If somebody came in on 20 medicines, they would walk out with at least 9, if not 15 of those medicines canceled. Right. And so
if we were to sit down together and say, well, let's take a root cause approach to medicine. Now, what does root cause mean? It's saying find out the cause of disease and address the root cause. We've either got a root cause approach or we've got a Band-Aid approach, which we call a pill for every ill. Oh, you got a headache. Oh, you didn't sleep well. What have you? Now, if you and I were to sit down and put our heads together and come up with a list of medicines that would genuinely be root cause medicines, it would be less than 20 medications, I would imagine, would have anti-infective agents. You might have hormonal therapies for people who have had a damaged gland, like their thyroid gland might have cooked itself and they need thyroid hormone, or they might need testosterone or something like that. They might even need insulin. But the list would be far, far shorter than what we're actually able to prescribe. Most drugs actually just treat symptoms. So what I presented on recently in a lecture called Fixing Medicine was a case of egregious polypharmacy. So there was a 71-year-old lady, and she was found to have slightly high blood pressure, which, by the way, have you ever gone looking for the all-cause mortality benefit of blood pressure medications, like for evidence that they actually make people live longer?
Well, for minimally elevated blood pressure, it's infinitesimally small.
It's an unsatisfying search. So anyway, so this lady was started on she had blood pressure that was elevated, so she was started on a blood pressure drug. Now, this particular drug is called a calcium channel blocker, amlodipine, and it is known to have a side effect of ankle swelling. And as you know, ankle swelling can also be a sign of heart disease. Or a drug side effect, surprise, surprise. So she ended up seeing another doctor who said, oh, you've got swelling of your ankles. Well, you must have too much fluid in your body. Let's give you some fluid tablets. These are called diuretics. They force the kidneys to expel extra water from the body, basically leading to a state of dehydration. Now, if you put an old lady on 2 diuretics, you can reliably predict she's going to start peeing. And guess what? She did. So she was diagnosed with urinary incontinence. So she was put on another drug for the urinary incontinence. Now, this drug has what we call an anticholinergic side effect, which leads to the sense of a dry mouth. And that was bothering her quite a lot. So she was given a drug to treat this, which is lovely. But eventually she ended up being on 17 separate drugs, including all these ones that were commenced in rapid succession, including 2 antidepressants and an antipsychotic drug, most of them which have falls risk as a side effect. Can you guess what happened? She fell over in her bathroom, struck her head on the basin as she went down and fractured her spine. Now, the interesting thing was that 2 days ago, I was seeing a gentleman who was in quite a pickle last year. He came to see me and he was in quite significant heart failure. His lungs were full of fluid. His legs, he had, fluid pitting edema up to his wazoo. He really wasn't in good state. And he embarked on what you and I might call a proper human diet. He's lost 20 or 30 kilograms in the last few months and he's in a much healthier state. And I just saw him a couple of days ago. I said, how are you going? He goes, I had a fall. I said, oh, you tripped over? And he's like, no, I fell. I just fainted. I had a look at his drugs and he was on 2 diuretics and 2 different blood pressure medications. And I just think, oh no. And it's like, once you get healthier, we need to take you off of these drugs. These drugs are causing side effects. And he went to an emergency department. They gave him a full cardiovascular workup. They said, sorry, buddy, we don't know why you fell. See you later. Did nothing. And it's very clear that he's on multiple drugs that are causing increased risk of falls. And I suspect that if we appropriately change his drugs, as in deprescribe, which, as you know, we're never taught how to do,
Right.
It always makes us feel uncomfortable because we're never told to deprescribe. We're never taught how to do it. But if he goes through an appropriate process of deprescribing, his chance of having another fall will be way down.
Absolutely. And my heart goes out. The poor woman on 17 different medications. People think, well, that's probably a special case, probably very rare. That is so common in people over the age of 50 or 60 or older. That is so common that now doctors are actually writing books about pharmacology and deprescribing. Finally, but
it's harder than you think.
It is. It's not easy, especially for some drugs. It's a very touchy thing to do it too quickly. And so I'm glad there are books about it. But you're right. As a young doctor, I never thought about stopping a medication. I didn't think that was my job.
Well, let's take proton pump inhibitors, so an acid reflux medication, right? So incredibly commonly prescribed. So when I was in medical school, we basically got told safe as houses. As long as you want, suppress the natural acid secretion in the stomach, that you can risk becoming deficient in a lot of electrolytes, calcium, magnesium, so on and so forth, which is why you have an increased risk of osteoporosis, increased risk of community-acquired pneumonia because of aspiration risk, increased risk of dementia because you reduced absorption of B12.
And so in the United States, this would be Nexium, Prevacid, Prilosec. Those are probably the biggest 3, and there's a couple more. Go ahead, doctor.
So they're just awful drugs long term.
Yes.
And if you have a look at the prescribing information, and the thing about prescribing information is that by law that has to be accurate. Otherwise, those execs could go off to jail. So that little leaflet inside the drug box, that's the holy grail for accurate drug company prescribed information, which is I love sometimes, which is why when you look up on Crestor, you'll see it causes diabetes and so on and so forth. But that's another side tale. But these side effects of these proton pump inhibitors are huge. And the problem is that if you suddenly stop them, you will get a side effect. So they took a bunch of volunteers and they said, here, take this drug. And then these volunteers were healthy. They had no reflux before they started. Then they stopped. 40% of them developed symptoms of reflux. So this is called rebound acid hypersecretion. So what happens is by taking this drug, you suppress the natural acid secretion of the body, and the body says, I need the acid. So it dials up the acid production to counteract the drug. So if you suddenly take the drug away, you take off that brake, you're going to have a lot more acid being produced. And this is why when people inappropriately, they may appropriately, but usually inappropriately get prescribed one of these proton pump inhibitors, when they try to stop it, they get the reflux and I still need to take it. They end on it indefinitely. So you actually have to wean off these drugs quite slowly. You start halve it again, do it second daily, however you want. And I usually, have a protocol over, 2 to 6 weeks, depending on how long they've been on it, where we actually get to wean them off. But you think we're taught how to do this in medical school?
Nope.
Not in your life.
Nope. And for many people, when they begin a proper human diet, whether that's low carb, real whole food, or ketogenic, real whole food, or ketovore or carnivore, wherever you fall on the proper human diet spectrum, most people with chronic heartburn, their heartburn gets substantially less severe. And so we've had so many people in the private community be able to come off of these. But if they come off them too quickly, they're like, oh, I just stopped it cold turkey. I had the worst heartburn I've ever had in my life. I got back on it. Then I have to have this conversation with them. You got to do it slowly so you don't have the rebound acid reflux.
Well, do you know Dr. Eric Westman?
Sure.
So I believe he did a study, it's a bit of an older study, and I don't think enough is made of it, where they actually did esophageal probes. I think it was Eric, I hope it is, esophageal probes, and they were measuring the acidity in the food pipe. There's not meant to be acidity in the food pipe. And they actually found that when people went on low-carb diets, they had a significant reduction in the acid levels of the food pipe, the esophagus, within 6 days.
Yep.
And interestingly, I've actually delved into the mechanisms of this, and a lot of it is not so much the low carbohydrate element, but the low grain element, because with the grains, you can get what we call lectin cross-linking of IgE, which leads to histamine release, which leads to acid secretion. So it's actually, there is a mechanism by which grains, because they contain these carbohydrate binding proteins called lectins, that will actually specifically induce acid secretion. So it's nice. We've got the biological mechanism, and we've got the experimental proof that when you go on a low carb diet or you cut some of that crap out of your diet, very, very rapidly you get improvements.
Yeah, and we see that all the time. One of our community members has a question. What are your thoughts about the PCSK9 inhibitors? In the United States, this would be Praluent and Repatha are the two most common brands.
Right. Well, they're very effective at lowering cholesterol.
Yeah.
Damned effective. Here's the thing. Is cholesterol essential for life? I don't know. Okay, well, that's one conversation. Here's another question. Have they ever been proven to statistically significantly extend lifespan? So I ask patients, when patients come in on a drug, I like to ask them why. And they usually have no idea what I'm getting at. And I say, they say, I'm taking it because my doctor told me to. But why? Why are you taking it? And we get down, what I want them to say is, I'm taking it because I think it will make me healthier. I think it will help me live longer. I can enjoy a longer retirement and see the grandkids grow up. You know, I want a mortality benefit. Yeah. So, and mortality is one of those fabulous markers that is very difficult to fudge. Even a disingenuous, dishonest researcher has a hard time saying that somebody's alive when they're under 6 foot of dirt.
Yes.
So it's a brilliant endpoint because it's accurate, it's objective. So if we actually we don't worry about surrogate markers like cholesterol, but we say, well, you know, when we give you this drug, do you actually live longer? That's proof that will be offering you some benefit. And to my knowledge, there's not been a single study that's proved any mortality benefit for the PCSK9 inhibitors. Now, this probably segues, if I may hijack this a little bit, into a conversation on cholesterol. And I often see this, there's two schools of thoughts in the carnivore community.
Yes.
There's a school that says cholesterol, it can be as high as you like, it's never going to be a problem. And there's this other school says, I want to have a bet in each camp. Look, I don't think cholesterol's bad, but everybody else says it is, so I still want to take a statin. I want to lower it. And I think the truth is somewhere in the middle. Now, what do I mean by that? So if you've got high cholesterol, we can determine whether you're likely to derive a mortality benefit or a survival benefit from taking a statin by looking at something called your triglyceride to HDL ratio. And if you've got a good triglyceride to HDL ratio, that means low triglycerides, higher HDL, then the data very clearly indicates, and this is drug company owned data, which in an article with Ben Bickman and David Diamond, we did a couple of years ago, we very clearly made this, demonstrated this using drug company owned data, that you don't get a mortality benefit from taking statins. So we can assess high cholesterol level. First thing to do is to assess the triglyceride to HDL ratio, you know, and if you've got a good ratio, then there's really no reason on God's green earth why you would need to take a statin. But that doesn't mean that the cholesterol is fine, because there are, if we actually have a look at the all-cause mortality curves, we see this little U shape. And we know that when people's cholesterol goes too low, their chance of dying significantly increases, but also, and to a lesser degree, lower gradient, but still exists, when the cholesterol is very high, there does appear to be a statistically significant increased risk of death. And then I believe the reason for this is because cholesterol production does associate with other health-related parameters, such as nutrient deficiencies and chronic inflammation. For example, if any of your listeners out there want to do a quick internet search, just type in B12 deficiency and cholesterol, and you'll see that there's very clear evidence that B12 deficiency increases the biosynthesis of cholesterol. There's other factors that can increase cholesterol as well, a folate deficiency. What about an underactive thyroid? What about a condition, we call it hemochromatosis, a genetic tendency to overabsorb iron? It doesn't have to be full-blown hemochromatosis where you've got two affected genes. You could be heterozygous and just have one affected gene. That also will affect your cholesterol levels. So there's multiple aspects to health that we're starting to have more visibility of that can consequently lead to an elevated cholesterol level. So in my patients, if they're coming in with a very high cholesterol, I do two things. So first of all, we have a look at the triglyceride to HDL ratio. We want to determine, is this atherogenic, artery clogging, or non-atherogenic? And number two, I still want to find out why it's high. Is there some underlying pathology that we're missing that we don't have visibility of? For example, I've seen high cholesterol in people with mold exposure. Not what you'd expect, but when we actually have a look for antibodies against mold in the blood, we see they're sky high. And when we address the mold issues and we say, oh, okay, well, I've been exposed, I've had a water leak in my car, I've just ignored that moldy smell, get a new car. And over a period of months, the cholesterol, without doing anything else, will just come back to normal. So there's multiple possibilities, multiple potential causes for these things. And I think rather than being in one camp, we're saying, oh, all cholesterol is fine, or, all cholesterol is bad, everybody needs a statin. I think the truth is somewhere closer to the middle.
Yeah, I totally agree. And can you see, I hope the viewers can see this concept. When a doctor's got a pill for every ill, it actually actively discourages them from looking for root causes. Because when somebody comes in with really high cholesterol, does the doctor say, I wonder if they have undiagnosed hypothyroidism? I wonder if they have folate or B12 deficiency? I wonder if they have mold stuff? No. They say, oh, you need a statin. They put them on the statin. That's the end of the matter. None of the root causes that actually might make the patient die sooner, it never occurred to the doctor to look for any of that. He can fix that problem, just put him on a statin or a PCSK9 inhibitor. Same goes for heartburn, reflux. If somebody if a relatively healthy person is having reflux, it's either from their diet or they've got some underlying condition that needs to be diagnosed. But when the physician has his prescription pad, oh, I'll just put you on Prevacid or Nexium. Boom, heartburn's gone. Okay, there we go. Problem solved. Not thinking maybe I need an EGD to look for a gastric ulcer. Maybe I need to look for an esophageal problem or a lower esophageal sphincter problem or any other number of problems. It encourages doctors to be lazy.
I think you're right. It does lead to unthinking doctors.
Yes.
And the trouble is with that, so doctors are often being put up on their pedestal. One thing that really annoys me is when you hear stories of these doctors, they're the kind of doctor that have got their cup on their shelf that says, don't confuse my medical degree for your Google search.
Right. That guy.
Anyway. But let's talk about a more positive example. So I had a patient who I just saw last week, and he told me a story. He had consulted previously with a bloke called Bob Atkins. You may have heard of him, Dr. Atkins.
Yep.
And he was way ahead of his time, and he was an incredible thinker. Now, we tend to think of him as being, all about nutrition, protein, fat, blah, blah, blah. I can tell you he wasn't. He was a real thinking doctor, because this patient I was chatting to, he said, oh, yes, he had done a test on me because one of my questionnaires that I give to patients, we ask them, do you have amalgam fillings? And he said, yeah, I used to have amalgam fillings, but, Bob told me about them, and he underwent EDTA chelation therapy to get rid of the mercury toxicity that he found in his blood. And I'm sort of thinking, there you go. There's a real thinking doctor. His root cause, he was so far ahead of his time. And, and I think you can predict that, would like to hope that most doctors with visibility of nutrition and who understand the impacts of nutrition, they're just not limited to nutrition, that they're able to think about all environmental exposures and think about things across the board. And as you said, they're not just prescribing a pill. They're not just, you've got a headache. I take a pet peeve of mine. There's two pet peeves, is menopause, and I don't know if I should say this, but menopause is the scapegoat used by the diagnostically incompetent. You have a female, which is, what's wrong with you? Oh, I have trouble sleeping. It's menopause. What's wrong with you? I have sweats. Oh, it's menopause. And too often we use these symptoms as diagnoses when they're not their symptoms. So if we take sleep disturbance, a standard doctor says, okay, what, you have sleep disturbance? I have a sleeping pill. No, sleep disturbance is a symptom. It's not a disease by itself. It's not a diagnosis by itself. Did you know that 75% of people with inflammatory bowel disease have pathological sleep disturbance? How much sleep disturbance you think people are taking these Z-class drugs for when they've actually got undiagnosed autoimmune inflammation? And it's really obvious when you think about it. So if you drink 2 liters of water before you go to bed, what's going to happen? You're going to get up, you're going to pee in the middle of the night. You're going to have a broken sleep. And we actually, funny story from the Australian Institute of Sport, they were focused on, you have to have light straw-coloured urine, otherwise you're dehydrated. So they were having athletes drink so much that when they woke up in the morning, their urine would be light straw-coloured. Now, as you know, a working kidney, the job of a kidney is to concentrate the urine. One of the first signs of a failing kidney, I do a urine osmolality test first thing in the morning. And when that starts to get dilute, that's the first sign of a failing kidney. So anyway, these athletes are having terrible, terrible sleep disturbance. And then in short order, they said, okay, that's a failed experiment. Okay, go back to not drinking before bed because, you best want your sleep. But why do you wake up? Because you get this visceral stretch on your bladder. You get visceral irritation. So if you're getting and viscera is basically anything contained within this part of your body. So if you're getting any irritation of that, say with inflammatory bowel disease or reflux or something like that, it is going to disturb your sleep. So when people are sort of treating sleep disturbance as a symptom and they're not thinking deeper about what the underlying cause is, those people with inflammatory bowel disease, they can do as much sleep hygiene as they want. They can wear all the bloody blue light filters and earplugs and eye masks and all that, and it's not going to help unless you deal with the root of the problem. And like yourself, I try and get to the root of the problem.
Yeah. How would you recommend that a patient, I saw a question here from one of our tribe members, how would you recommend a patient go about talking to their doctor if they think that they're taking prescription medications that may not be giving them any benefit? Let's talk about that, and then also let's segue into patient rights and the rights that patients should have in the doctor's office.
Okay, so in terms of talking to your doctor, so doctors aren't evil. So, I've been criticized in the past, so I don't think doctors are deliberately making people think. I think doctors are ignorant for the most part. I think it's more negligence than anything else. So look up the list of the side effects on the medications you're taking and present them to your doctor. Your doctor may have no visibility of these side effects. They may just be mindlessly prescribing them. Also, number 2, ask your doctor, why am I taking this drug? All too often I ask my patients, why are you on this drug? And they can't tell me. Their doctors haven't explained to them. Or it was started by an old doctor who they're no longer seeing, and their current doctor just continues on status quo. Yep. So I think those two, bring to your doctor's attention what the side effects of the drug are, and bring to your doctor's attention why you might need that drug, or more importantly, why, when you're on a healthy diet, why you may no longer need the drug. So if you used to have high blood pressure of 160 and you went on a healthy diet, and your blood pressure would naturally fall to 120, if you still keep taking the drug, it'll go down to 100. So, when you improve your physiology with diet, you're no longer the same person. And the drugs that may not have had terrible side effects, their side effects can increase in the same way that if you have a diabetic who's injecting insulin and they go on a ketogenic or a carnivore diet, if they keep injecting that same dose of insulin, there's every chance they could enter a hypoglycemic coma, which could kill them. So, just make sure your doctor's got visibility of those two things. Then you're talking about what rights patients have. And I think you and I are absolutely on the same page here. So in my consultations, I open my consultations by saying, just to let you know, you can record this consultation. Usually first time I see a patient, there's a bit of a stunned silence. It's like, why would I? Oh, okay. Yes. Thank you. Please. And
because they've never been told that in their entire life.
They've never been given permission for that.
Yes.
They've never, but I think it's really important. So
I love that.
I like my patients educated. These kind of, if you're the patient up there who's doing your Google searching that doctor's mug is talking about, you're my kind of patient. I want my patients empowered. And that also empowers me as a doctor. And so here's the thing. If you come in on 12 different drugs, I don't want to put my medical registration at risk by saying, oh, your doctor's a bit silly. I think you shouldn't be taking this drug. No, well, I rely on something called informed consent. So if I educate you as a patient to what the science is, you are then in a position to make the decision that is right for you. That's called informed consent. You've been given all the information and you're the only person who truly understands your particular circumstances. You make the decision right for you. So I think the number one unyielding patient right is to be provided with factual, unbiased information.
Absolutely.
And to not be then pressured into doing something. So as doctors, we gaslight our patients all the bloody time. You hear about cardiologists. Well, if you're not going to take this statin, you're no patient of mine, you might as well die. You could die at any time. We scare patients without any evidence for it.
Yep. So I would like to take this opportunity to encourage everybody listening to this video from this day forward. Anytime you go to a doctor's appointment, your family doctor or a specialist, I want you to pull out your cell phone and say, you won't mind if I record this, doctor, because I want to listen to it later because I might miss something. I encourage all you guys to do that. And if the doctor has a problem with that, because first thing's going to happen is the doctor's going to be on much better behavior when they're being recorded. I promise you, it's just human nature. They're going to be much nicer. They're going to be much more thorough, much more complete, and they'll actually answer your questions if you're recording the conversation. But also what's not going to happen is the gaslighting that he was just saying, because he knows he's being recorded. He's not going to say, well, you'll die within a week or two if you don't take this statin, because he'll know that you could play that for who knows who you'll play that for, right? But you're going to preface it with, I want to listen to this because I don't want to miss anything, and my health is very important. So I'm going to record this if that's okay with you. And if they have a problem with that, that's a huge red flag that you might need to find another doctor.
Absolutely. I mean, I've found I've not had a single bad reaction from a patient in doing this. And some patients, what I also do is at the conclusion of each consultation, I email the patients a complete copy of my notes. Perfect. And when I order testing, I copy the patients in on those test results. So we try and have as much openness and transparency. And I say to my patients, if you have any questions about anything that I've said, you're entitled to question why I've made that recommendation. Looks like I've just lost my camera.
I can still hear you well.
Okay, well, we'll keep going.
Yeah.
So that was a bit distracting there. So I tell the patients that they're entitled to question any bit of advice that I offer. And if I can't point to peer-reviewed science, then they should question what I'm saying. I also explain to patients that the person they should trust the most is themselves. Nobody cares about them more than them. And even though I try and be an unbiased, transparent doctor, the simple fact is there's still conflicts of interest. There's still, if I see somebody on a statin drug that I think is inappropriate, but that was prescribed by a high-ranking professor at a top Sydney hospital, I know that if I give explicit advice and say, well, that's just silly, then that's not very professional, number one, and it's not necessarily good for my career. So I do not directly contradict other doctors. What I do is I say, here's more information. You can make your own decision. But what I recommend you do is you approach your other doctor, and in the same way that I've provided you with evidence of a certain effect, I'd like you to approach this other doctor and request that they provide you with evidence to support their basis.
That's a
and you know
brilliant
what?
strategy.
No other doctor has ever taken the patients up on that.
That's a brilliant strategy. Here in the United States, we're very good at getting informed consent for any surgical procedure, even a minor surgical procedure, an excision of a mole or implantation of a birth control device. But when it comes to prescribing pharmaceuticals and then also vaccines, we are terrible at giving and getting informed consent. So doctors will say something about a statin drug, Zocor, Lipitor, Crestor. Well, you just need to take this. You just need to listen to me. That's not informed consent. That's not even close to informed consent. And so I don't know what the solution to this is. I love your solution. Have the patient record the conversation and ask as many questions as they can. But many doctors are just not going to allow that. And they don't want to be required to give informed consent when it comes to pharmaceuticals. And I can hear the argument, oh, it would take, this person's on 15 medications. It would take me an hour and a half to get informed consent on each one. Then maybe you should revisit that medication list, doctor, and get them off some of those medications, right? But that's a huge problem in the United States. I'm not sure how it is in Australia. Do you have to get informed consent before prescribing a pharmaceutical, or can you just say, here, you need this, take this?
I don't do a hell of a lot of prescribing, but I don't think we have enough of a focus on informed consent. All too often I see patients and they have side effects from a drug, and I say, did you know this drug causes this side effect? No. What about this side effect? What about this drug? What about this drug? And it's complete ignorance. Yep. So one can only assume whether or not there's a requirement for informed consent. I think that it's fair to say that that standard is not met in day-to-day practice, not routinely anyway.
I totally agree. One final question I want to ask you. I'm a primary care physician. One of the things I'm looking for when I see patients is signal. I'm looking for signal. So when I used to tell people who are overweight and had type 2 diabetes, hey, join the gym and join Weight Watchers, that's what you need to do. When they would come back in 3 months or 6 months, I would see zero signal that had helped them at all. And so I became completely disillusioned with recommending diet and exercise because it didn't ever help, right? So one signal I keep hearing from the carnivore community, and I've actually experienced this myself, so full disclosure, is that back when I was eating the diet filled with vegetable seed oils and grains and junk, I was almost allergic to the sun. If I was out in the sun, I'm very fair, northern latitude DNA, I would burn within 10 minutes, especially at the beach and just full sunlight in the summer. 10 minutes, I was going to have a sunburn. And now, since I've been a carnivore, I can stay in the sun 3 or 4 times longer without getting a sunburn. And also, I can actually get a tan now. As you can tell, I'm quite ruddy. I've been ruddy all my life. That's my heritage, my DNA. So don't make fun of my skin color. It's insensitive. But I can actually get a tan now, and my arms are darker than Nisha's arms, and she's half Puerto Rican. But I can actually get a good tan now, whereas before I could not get a tan at all. Do you have an explanation, a physiological
now, this is
explanation?
Really interesting. Phytoplankton, 500 million years old. They're very vulnerable to the UVB radiation, which is just the right wavelength to damage DNA. So they actually synthesize vitamin D, and vitamin D molecule is just the right size molecule to absorb the wavelength of UVB radiation and protect phytoplankton from the damage. So basically vitamin D throughout history has had a role as a sunscreen. And it appears to be that in humans today, we still have that role. So why do people with dark skin not secrete much vitamin D on exposure to the sun? Because the melanin serves the same purpose as the vitamin D, absorbing the UVB wavelengths and protecting their skin. They don't need to secrete much vitamin D. Why do pale skin people secrete vitamin D? Well, because we need to, otherwise we will burn. But it's only from the UVB radiation, which is more found when the sun is closer to being overhead. Because of the wavelength of UVB, it gets attenuated when the sun's coming in on an angle. It gets attenuated through the thicker mass of atmosphere that it has to pass through. So UVB is actually absolutely associated with skin cancers, and I don't believe offers any major benefits. Now, the interesting thing is that what's vitamin D made from? What's the substrate for it? It's cholesterol.
Yeah.
So if you're having a whole lot of seed oils and stuff like that will affect your normal biological functioning of cholesterol, then you won't be able to produce as much vitamin D. You will burn much easier. Ansel Keys, he actually did a study, and they actually, people in England, looking at how much time they were exposed to the sun, and they found that when you were exposed to more sun, your cholesterol level actually fell. Why? Because the cholesterol was then needed to synthesize vitamin D. So it's actually the ability to synthesize vitamin D from cholesterol, which can actually improve your natural protection from the sun. Then the question is, do you actually need to be exposed to the sun for vitamin D levels? And historically not. Well, the Inuit, they never had low vitamin D levels, did they? Because vitamin D, being a fat-soluble vitamin, is in food. So if you're eating, whale blubbers and all these other foods, seafoods that are very rich in saturated fat, you're also getting all the vitamin D you need there. So in a natural diet, we can actually get all the vitamin D we need. And our modern diet is so far removed, the standard American and Australian diets are so far removed from what is an appropriate diet that we now consider you can't get vitamin D from diet. Well, you can't get it from a modern diet, but you can get it from a proper human diet. Absolutely. Now, the other interesting thing is that the vitamin D level in your blood, the reason it associates with health is because, remember we said it's fat soluble. So if you're big and fat, you've got this massive reservoir or sink for vitamin D, and it will actually absorb the vitamin D from your blood, leading to lower levels of vitamin D in the blood. And this has been shown by research that when we give people vitamin D supplements or expose them to UV radiation, that if they're overweight, the vitamin D levels in their blood don't increase by as much because a lot of the vitamin D is taken up in fat stores. And that's the connection between metabolic health and lower vitamin D levels. So one, you can get all the vitamin D you need from healthy diet. Number two, if you're overweight, your vitamin D level will read lower, but that's a correlation and not a causation. Now, one other thing is, this is not me saying I don't think sunlight is healthy. Sunlight is incredibly healthy because there's another UV that we get called UVA, and that stimulates the release of something called nitric oxide, which has been shown to lower blood pressure. It also lowers HbA1c. UVA exposure lowers the level of glycated hemoglobin. So UVA does a lot of good things, and you get exposed predominantly to UVA when the sun is passing through a thick mass of atmosphere. It's coming in on an angle. And that's because UVA is a longer wavelength, doesn't get attenuated the same as a shorter wavelength UVB does. So if you have a look at your shadow, that will give you an idea of how the angle the sun's coming in. If your shadow is at least as tall as you are, you're getting predominant UVA exposure with less UVB exposure. You're generating the nitric oxide, which is why even people with skin cancer, they've actually been shown for squamous cell carcinoma and basal cell carcinoma to live longer, almost 10 years longer. The magnitude of effect of exposure to sun in terms of life mortality benefit is equivalent in reverse to the magnitude of detriment that you have when you're a smoker. It is absolutely huge. Population-based data shows that people with squamous cell carcinomas and basal cell carcinomas live longer. And I believe the reason for that is because, sure, they're getting skin cancer from UVB damage, but they're getting the UVA, the nitric oxide exposure, which is hugely important to health. It's got immune regulation properties, blood vasoactive properties, so on and so forth. So in my world, to get the best of both worlds is to expose yourself to the sun. When you're getting predominantly UVA, you reduce your risk of getting sunburnt and skin damage from UVB radiation. And if you've got high cholesterol levels and you're on a healthy diet and you're producing a good amount of vitamin D, that will provide another layer of protection from the UVB radiation. So, yeah, that would be my take on it.
I love it. I love it. Dr. Paul Mason, thank you so much for doing this. It's always a pleasure chatting with you. Tell people watching where they can find you if they really resonated with your message.
Well, I do a few lectures from time to time, and they go onto the Low Carb Down Under YouTube channel, which and you've got videos on there too, I believe. So I'm in illustrious company. I've got a Twitter handle, and from time to time when I have the chance, I'll do a bit of tweeting. But for the most part, it's the Low Carb Down Under YouTube channel, and I'm hoping that in future I can be a guest on your show again.
Hey, I think we need to do round 3 in the near future. Thank you so much, Dr. Mason. Have a good day.
Pleasure's all mine. Thank you so much.
See you next